Good evening, everyone. I am Dr. Geethu Antony, consultant endocrinologist at Masleva Medicity, Palai, Kerala. We'll be discussing an interesting case scenario today. This is a patient, Mr. AB. He's a 58-year-old gentleman with history of type 2 diabetes for the last 4 years. So he's also having associated comorbidities like hypertension and dyslipidemia and obstructive sleep apnea. On examination, he's obese with BMI of 32 kg per meter square, and he has features of insulin resistance. So he has come to my clinic with for his optimization of his diabetes control. So his lab investigations revealed an suboptimal control of diabetes with an HbA1c of 8.3. With a mild reduction in eGFR of 70 ml per minute per meter square, with increased microalbumin in his urine with an microalbumin creatinine ratio of 45 milligram per gram. And he has an increased triglycerides with levels of 250 milligram per deciliter with low HDL 35 and normal LDL levels of 69. And he has mild increased elevation in AST and ALT, which is suggestive of a non-alcoholic fatty liver disease. See his medications, he is currently on a single oral antidiabetic drug, that is metformin, at a dose of 2 grams per day, and he is on 2 antihypertensives, lisinopril and metoprolol, with an optimal hypertensive control. And he is on an high-dose statin, atorvastatin 40, and on aspirin, 81 mg prophylactic dose of aspirin. So this is a patient who has come to a clinic with short duration of diabetes. He is young. He has other atherosclerotic cardiovascular disease, but there is no established CVD. He has very early diabetic nephropathy. So what will be the optimal drugs which you can add in this patient? So when we talk about diabetes control, so we know that this patient needs a better glycemic control with a target HbA1c less than 7 or even less than 6.5 if we are able to give him this level without significant hypoglycemia. And also he is obese, so we should not give him a drug regime which can provide him weight loss. And also he has features of early diabetic nephropathy and also other risk factors for cardiovascular disease. So he needs drugs which are beneficial in these aspects also. So when we discuss the options with this patient, my patient was willing to start on another oral anti-diabetic drug, but he's not willing for any injectable drugs. So the main concern he had is that the increased number of pills. So he's already on 5 drugs per day, and he was concerned that adding the 1 or 2 more drugs might increase his pill numbers. So, and for optimization of his diabetes controls, he will probably require another 2 drugs because his HbA1c needs to be reduced at least 1.5. So we need to probably add him on more than 1 drug at this point. So one of the combinations which you can use in this case scenario is a combination of an SGLT2 inhibitors plus an gliptin DPP4 inhibitor. So which these 2 drugs as a combination can provide the patient weight loss, and also these drugs are cardiovascular beneficial and or cardiovascular neutral without much risk of hypoglycemia. So when you talk about combination of SGLT2 inhibitors and DPP4 inhibitors, we have the first available combination of empagliflozin 25 milligram and linagliptin 5 milligram is available as a fixed drug combination with a once daily dosing, which makes it very favorable for this patient. So when we talk about these drugs separately, we know that SGLT2 inhibitors acts through inhibition of SGLT2 inhibitor transporter in the PCTs of kidney, which increases the urinary glucose excretion. So its action is independent of insulin secretion, and because of this insulin independent action, it can be given to any patient at any stage of the disease course. Even at advanced diabetes, this drug is found to be effective. And we know the action of DPP4 inhibitors, which acts through increasing the incretin hormones, predominantly the GLP-1, and also it predominantly the incretins augment the glucose-dependent insulin release, and also it inhibits glucagon release. So these two drugs has complementary actions in diabetes control. So the combination of these two drugs can provide an additive glycemic control. And when we talk about the cardiovascular safety of these drugs, we know that empagliflozin has is proven to have a cardiovascular superiority when compared to placebo, and also it has been proven to reduce the progression of diabetic nephropathy. And linagliptin safety has also been proven. Cardiovascular safety has been proven in the Carmelina and Carolina trial also, and we know that the drug is renal safe also. And how far the HbA1c reduction can be attained with this combination of empagliflozin and linagliptin once daily fixed drug combination. So the studies have shown that the HbA1c reduction can be attained up to 1.81% from baseline when you add this fixed drug combination along with metformin. So the study have at the end of 52 weeks, the percentage of patients, the mean HbA1c reduction in the study was around 1.81, with a higher percentage of patients achieving HbA1c less than 7% when compared to the individual drugs alone. And also these two fixed drug combinations can provide your patient a good glycemic control without added risk of hypoglycemia and also weight gain, which makes it favorable in many of our diabetic patients. And also the overall lipid profile shows an improvement when you give these two drugs. And also in NFLD or NASH, both SGLT2 inhibitors and DPP4 inhibitors has been proven to have benefits in reduction of NFLD. And one of the major side effects of SGLT2 inhibitors is increased incidence of genital infections. And there has been some studies which shows that when you add on an DPP4 inhibitor along with SGLT2 inhibitors, this risk of increased incidence of genital infections also might come down. So in coming back to a patient, so in this patient who was a 54-year-old gentleman with suboptimal glycemic control, who was obese with other risk factors like hypertension and hyperlipidemia. If you add on a fixed drug combination of SGLT2 inhibitor and DPP4 inhibitor, that is EMPA plus linagliptin, once daily, you can provide a good glycemic control with the added benefits of weight loss and also CV safety or CV benefits and reduction in CKD progression. And also the risk of hypoglycemia is absolutely nil with this combination of drugs, and the drug is very convenient for your patient because it's once daily dosing and it can be also taken at any time of the day. So probably this fixed drug combination works really well in this patient. Thank you.